Malawi. Thank you.
Thank you for that introduction. And hopefully with this talk, I'll be able to get at some of those alternative options for reaching female sex workers. As we've seen throughout the week, and especially within this session, the HIV prevalence among female sex workers globally remains disproportionately high, despite decades of prevention efforts. Malawi has one of the highest HIV prevalences among female sex workers at approximately 70%. This prevalence is notably higher than the countrywide HIV prevalence of 10%. HIV-infected female sex workers will continue to transmit HIV to their uninfected partners and not benefit from the health outcomes of ART without timely engagement into treatment. Timely identification of HIV-infected and ART-eligible female sex workers are the critical first steps prior to ART initiation. The HIV care continuum provides us a representation of these visual steps. Although estimates are limited among female sex workers in Africa, we've seen that generally female sex workers access care infrequently and have a low uptake of ART. Empirical evidence from non-female sex worker populations within sub-Saharan Africa has shown that, on average, 30 to 60% of people living with HIV are lost between the steps between HIV diagnosis and ART initiation. Those who are lost are responsible for the gaps that we see along the continuum. Mobile HIV testing integrated with point-of-care CD4 testing could close the gaps we see in the continuum by reducing known barriers to CD4 testing. We've seen that mobile HIV counseling and testing services are an effective way of reaching many key populations, including female sex workers, in resource-limited settings. Traditionally, newly diagnosed through a mobile HIV testing unit are then referred to a district-level or standalone clinic for follow-up CD4 testing to determine their ART eligibility. However, the barriers that affect this linkage to care for CD4 testing are numerous. They can include perceived stigma at the clinic, traveler distance to the clinic, or the long wait times at the clinics to receive the testing and results. Providing mobile point-of-care CD4 testing can, along with HIV testing, may reduce these barriers that we see. The point-of-care CD4 analyzer is a small and portable device that generates a CD4 count using minimal supplies within approximately 20 minutes. The analyzer uses a single-use cartridge that collects whole blood directly from a finger stick, and then that cartridge can then be directly inserted into the analyzer. Because it's rapid, portable, and usable outside of a laboratory setting, this technology can alleviate the need for additional testing supplies, clinic and laboratory staff burden, and processing logistics. Point-of-care CD4 testing can also reduce the time to ART initiation, as it provides the same-day HIV testing and ART eligibility assessment at a testing site not based within a clinic or laboratory. Therefore, our objectives were to provide one of the first integrated mobile HIV and point-of-care testing units for venue-based female sex workers within Lilongwe, Malawi. We also described the HIV seroprevalence, ART eligibility by HIV infection awareness, and ART use among those that are previously diagnosed. We also discussed some of our indications of feasibility and acceptability of point-of-care CD4 testing. Just to orient everyone, in Malawi, the national guidelines stipulate that women initiate ART if they have a CD4 count below or equal to 500. And since July 2011, when Option B Plus was implemented, women who were currently pregnant or breastfeeding were allowed to initiate lifelong ART. This analysis was part of a cross-sectional descriptive evaluation of engagement along the HIV care continuum among 200 female sex workers in Lilongwe, Malawi. We used venue-based recruitment to identify female sex workers from 23 different venues where women were known to solicit sex. Women at the venues were approached and considered eligible if they were at least 18 years of age and self-identified as a female sex worker. The definition that we used for a female sex worker for this study was one that was previously used by the Malawi Ministry of Health, which was a woman receiving money in exchange for sex, either regularly or occasionally up to 12 months prior to the date of our survey. Women who consented to participate received a behavioral quantitative survey to obtain detailed information on demographics, pregnancy history, transmission risk behaviors, history of HIV testing, care, and treatment, and barriers to HIV care along the continuum. All of the women who participated received HIV rapid testing using the Malawi National HIV Testing and Counseling Guidelines. Among those that were positive based on the rapid tests, we also collected dried blood spots to obtain HIV RNA levels, and we conducted point-of-care CD4 testing. Briefly, our study cohort of 200 female sex workers were predominantly young, and the majority were living within alcohol-serving environments. The median age of our cohort was 24 years, and 58 were living in a bar or bottle shop. 58% were living in a bar or bottle shop. Female sex workers in our cohort were highly active as sex workers with prevalent transmission risk behaviors. Women reported a median of 21 weekly clients, or about 3 clients per day, and nearly 1/4 reported inconsistent condom use with the clients. Our sample of female sex workers had an extremely high HIV prevalence of 69%, which is consistent to the estimate that we had seen earlier from a decade ago. Among those that infected, 20% were newly diagnosed through our study, and 80% were previously diagnosed and therefore aware of their HIV infection. Of those infected, 30% were not on ART and were considered ART eligible per the Malawi national guidelines. We then stratified by HIV infection awareness. 63% of those newly diagnosed female sex workers were identified immediately as ART eligible, with a median CD4 count of 305. The women in our study were provided written documentation of their results, and we also recorded their results within their health passports. They were then also received referrals to an HIV care provider to be able to initiate ART. Therefore, for this subset of women, the time between an HIV diagnosis and ART eligibility assessment was essentially eliminated. Among those previously diagnosed, 65% reported currently being on ART, while 22 were considered ART eligible and not on ART, with a median CD4 count of 391. An additional 13% were not yet eligible and therefore not taking ART. Among those ART eligible and not on ART, we explored the potential barriers for ART initiation. The most commonly reported barrier was a prior high CD4 count. This emphasizes the importance of regular monitoring of CD4 counts to ensure timely initiation for these highly active women. Additional, less frequently mentioned barriers included not having the necessary paperwork or test results for the clinic. Women also reported previously missing an appointment at a clinic and therefore found it difficult or perhaps embarrassing to go back. And also women reported not feeling sick or just in general not ready to think about their HIV infection. Notably, 3 of these 4 reported barriers are related to CD4 testing. We also identified indications of feasibility and acceptability of mobile HIV and point-of-care CD4 testing. Through our study, we successfully trained HIV testing counselors and data collectors, which it's important to note that none of them had previously received formal training as a clinician or a nurse. Among all of the infected female sex workers in our study, none of them refused to receive CD4 testing along with their HIV test results. They were also willing to wait approximately 20 to 30 minutes to receive their CD4 results. As long as ART initiation relies on CD4 counts, integration of frequent HIV and point-of-care CD4 testing for female sex workers is urgently needed in high HIV prevalence settings, including Malawi. To summarize, 30% of those infected in our sample of female sex workers were identified as ART eligible. Among those newly diagnosed, the majority were immediately identified eligible for ART initiation. Additionally, nearly 1/4 of previously diagnosed female sex workers were ART eligible not on ART, with many reporting a prior high CD4 count, suggesting that frequent routine CD4 testing for HIV-infected female sex workers who are not on ART is needed in order to provide that timely initiation. Prior to the broad implementation of an integrated mobile and HIV CD4 testing to close the gap to ART initiation, we have a couple of strategies we need to try out first. The first one would be to conduct a formal cost-effectiveness analysis for point-of-care testing among key populations, specifically female sex workers. Also, we need to develop effective trainings for lay community health workers to employ the integrated mobile testing unit that will hopefully alleviate clinic and laboratory staffing burdens. And last, implementation studies will be imperative to identify strategies that optimize integration and national scale-up of mobile HIV and point-of-care CD4 testing for female sex workers in high HIV prevalence settings. Before I end, I just want to thank my many mentors and collaborators, both at UNC Chapel Hill and UNC Project Malawi, in addition to our implementing partner, Theater for a Change, and our donors for their support throughout the study. And most importantly, I want to thank their participants for their time. Thank you very much.
Thanks very much, Catherine. We have time for a couple of questions. I see one at mic 2.
Eugenia Socias, Vancouver, Canada. Thank you for your presentation. I have a couple of questions. The first one, if you know how many of the women you referred for HIV care actually initiate treatment. And the second one, what are your thoughts with the implication of the point-of-care CD4 testing now that the guidelines are moving towards recommending ART initiation regardless of CD4 count? Thanks.
Agree. So to touch on your first one, unfortunately, we did not follow up the women to see and determine how many of them then were linked to care for ART initiation. I think that's definitely our next step. And in terms as far as the ART initiation guidelines and moving towards that universal treatment, I think that that is the way to go. Unfortunately, I think that may be a bit far off for some countries, and so I think until we reach that universal treatment, this point-of-care CD4 testing could perhaps close some of those gaps to ART initiation.
All right. I think that's it. Thank you,
you.
Catherine. Sorry.